Okay, and our final presenter this afternoon then in this room before we have a break, and again, don't forget, find each other during the break and through dinner and so forth. We have Mena Megellie, and is Bishore joining you, or is, okay? And Mena is a resident in family and community medicine at Mount Sinai Hospital in Chicago, and he's going to speak on physician-assisted death.
Thank you for the introduction. My name is Mena Megellie. I recently graduated family medicine residency in Chicago. Now I'm a family doc in Toronto. My friend Bishoy Khalil, who is the co-author of this, was unable to make it. He is a registered pharmacist. He is a... it's the cord, huh? He's a registered pharmacist. He is the director of operations for a company called Cubic Health, and he's an all-around nice guy. Depends on who you ask, though. So we have no disclosures. Before I start, actually, two things I want to mention. Physician-assisted death is not something that people typically like to speak about for a couple of reasons, because it's depressing or because it is complicated. But it is something that we should reflect upon, not just as healthcare workers or not just as the Orthodox faithful, but as human beings, because it's becoming more and more common and it's becoming more and more popular, especially since some states have legalized it, and it's legal in Canada and in some European countries as well. The second thing is physician-assisted. I mean, the terms that we use are very important. Physician-assisted suicide has fell out of favor because of the negative connotation of the word suicide. So for this article, we used physician-assisted death instead of physician-assisted suicide, except when I was quoting somebody verbatim. So His Eminence Metropolitan Callistos, in the Orthodox way, once wrote that since God is love and God created the world as an act of love, and since God is personal and personhood implies sharing, God does not remain indifferent to the sorrows of this fallen world. If I, as a human being, remain unaffected by another's anguish, in what sense do I genuinely love him? Surely then God identifies himself with his creation in anguish. And the bolded parts here are really important. A, God does not remain indifferent, and God does identify himself with his creation in anguish. And a prime example of that is when Christ wept for Lazarus at the tomb, which is very important because the incarnated God is also showed that he was also 100% human, and even though that he knew that he would raise him later. So the laws on physician-assisted death differ between the States and Canada, where I'm from, and Europe. In the States, there are 7 states where the physician-assisted death is legal on the condition that the disease is terminal. So the prognosis has to be estimated to be less than 6 months. And this differs from Canada, which is important. In Canada, there was a bill in 2016 called Bill C-14, and this shows that the physician-assisted death, or medical assistance in dying as they called it, shows that it can either be done by a physician or nurse practitioner, or it could be done, administered by the patient, him or herself, in the form of a prescription. To be eligible, you need to be 18 or older, you need to have government-funded insurance, you need to have a grievous and irremediable condition, and it needs to be a voluntary request, meaning that the doctor can't be the one who initiates it and say, hey, have you tried ending it all? And it has to require informed consent. For grievous and irremediable condition, it's defined by the Canadian Criminal Code. In Europe, it's legal in Switzerland and Belgium, and Netherlands, Luxembourg, Austria, Finland, and Germany. And in Belgium, Netherlands, and Luxembourg, those are the 3 places where you can kind of do it as an advanced directive, which you can't do in Canada. You have to be decisional at the time and say, I'm suffering too much and I request physician-assisted death. Whereas in Europe, you could make it part of your advanced directives. or your living will. So I interviewed 3 physicians in Mount Sinai Hospital in Chicago, Illinois, and I asked them, should we as healthcare workers permit patients who are suffering to choose their time of death? And I spoke to 2 palliative care specialists, 1 intensivist in the ICU, and for those 3, I spoke to them face-to-face in Mount Sinai Hospital, and for the clinical psychotherapist, I spoke to her via email. And these were their answers. Physician number 1 is the palliative care at Sinai, and he said if the patient is of sound mind and has cleared a psychiatric evaluation, I would permit assisted suicide because it is a form of informed consent, just like any other medical procedure. These patients are suffering, and even if the prognosis is fair, why would I let this person be in pain for 5 or 10 more years? So he was very by the book. He said, and he was seemingly compassionate. Why would I let this patient suffer? And it is like any other medical procedure, just like putting in a central line. Physician number 2 is another palliative care in Sinai who disagreed with physician 1, but they were interviewed separately. He said, I would not play a role in their decision to end their life because if I did, it would be a failure on my part. It means that I did not manage their symptoms as well as I should have as a palliative care specialist. So in a way, he kind of co-suffers with his patients and says, I undertreated this patient, and it's a failure on my part if they do opt in for physician-assisted death. The ICU attending said that physician-assisted death should be widely accepted if properly evaluated. We would not practice it just because someone is depressed or wants to commit suicide. It would be a multidisciplinary decision. Oftentimes the family needs to be involved, and suffering is not necessary. When she said this last line, I didn't write it down, but I asked her, so suffering is not necessary. I repeated it, and she said, no, it's not. And I said, suffering is never necessary? And she said, no, it is not. So she stood firm on that. The clinical psychotherapist was from Texas, and she said, as a psychotherapist, when I hear a physician-assisted suicide, my mind immediately goes to psychological pain. I treat many individuals who are in a lot of psychological distress, and at times they have considered ending their lives. I would argue that when we are depressed, bereaved, or in physical pain, we are not ourselves. I've seen it time and time and again. Once the depression lifts or the pain is resolved, my clients look back and can't believe they ever considered suicide. If a depressed person tells you they want to end their lives, treatment is indicated. I don't see physical pain as being any different. Treating a person's physical pain is a medical necessity, but taking their own life should not be part of the treatment choice. Our lives are not our own to take. If this were included in the conversation, it would make for a very brief one. And the main parts here are the ones that are bolded. If we are depressed, bereaved, or in physical pain, we are not ourselves. Therefore, our consent should be scrutinized more thoroughly. And that when that depression lifts, or that when when our pain lifts, then we look back and we regret our decisions to ever consider suicide or physician-assisted death. So just a summary of those 4 people that we interviewed. Physician 1 was 4. He placed autonomy first, which could be detrimental, according to an opinion piece in the New England Journal of Medicine. Bordeaux and company said that the New England the problem the problem is that giving individual autonomy absolute priority runs roughshod over competing values, protections, and needs, and ignores the harmful effects on other people and societal institutions, the medical profession in particular, and the general community. Physician number 2, who was against it, again blames himself for undertreating the patient. Physician number 3 is the one that said that suffering is not necessary, and the clinical psychotherapist was also against physician-assisted death, because she said we are not ourselves when we are suffering, and that patients who have good symptom management usually regret their consideration for suicide. The society is always heading in a utilitarian direction, because why would I not spend my energy and my time helping somebody who I can actually help? Yet, the Orthodox perspective, as His Eminence Callistos implied, shares in suffering and sees the beauty in suffering. The movement to die with dignity suggests that it's not dignified to die suffering. But the root of the problem is what the meaning of suffering actually is. So in our society, in the Western world, we say that suffering is a pointless affront or hurdle to our dignity. But in our opinion, as Orthodox Christians, suffering is a challenge that allows us for the opportunity to grow independence in God and in our neighbors. This means when we're sick, when we're weak, etc. So as you can imagine, the West would say, why in the world would you want to grow in dependence of anything, God, neighbor, or otherwise? But then it's important for us to see the importance of being dependent on God and in our neighbors as well. So is suffering important? We believe that something very special happens near death. A person reaches their utmost vulnerability, and vulnerability that they wouldn't normally allow themselves in throughout their lifetime. C.S. Lewis writes, "To love at all is to be vulnerable. Love anything and your heart will be wrung and possibly broken. If you want to make sure you're keeping your heart intact, you must give it to no one, lock it up in a safe or a casket of your own selfishness. But in that casket, safe, dark, motionless, airless, it will change. It will not be broken. It will become unbreakable, impenetrable, irredeemable. To love is to be vulnerable." Basically saying that if you're afraid to be heartbroken, then you truly can't have the full capacity to love. And at the time of death, we believe that the heart is the most introspective, the one that's most open to sincere and excruciating love. And that might be a big problem, might be a grave error on our part to remove that from our patients, even if they ask for it. So patient A versus patient B, this is a silly scenario, but both patient A and B have disease X. They both have a good 5-year life expectancy, and this disease is causing them to have crippling pain and suffering throughout these 5 years. The difference is patient A lives alone or is homeless. He's lonely, he has no social support, and does not feel a sense of purpose. Whereas patient B has good family support, close friends who visit frequently, and recognizes his role in the community or in his household. So if you were to ask somebody which one is more likely to opt in for physician-assisted death, most likely would be patient A. You don't need to be in the healthcare field to know that social support is important. Mother Teresa writes in No Greater Love, she writes, "Loneliness and the feeling of being unwanted is the most terrible poverty." And this is important because there are people in this world who are severely depressed and who are terribly lonely and who want to die. What can we do then to help these people? One can only imagine the sheer pain of being lonely coupled with the actual physical crippling pain that they have. While everybody has the right to be independent, we have a responsibility to be interdependent with each other. And that's important because society has to continue to the struggle of forcing itself out of the comfort of self-interest and encourage itself to open its hearts and minds to those who are weaker and more fragile. So in this regard, physician-assisted death would be a shortcut out. What would happen if the physician-assisted death floodgates were opened and it was legalized everywhere in the States and in Europe? Government entities, third-party payers, insurance companies, healthcare institutions would be inclined to find ways to encourage the disabled and the debilitated to end their suffering because it reduces cost. But this is problematic, and you can compare that to the poor living in our society, on our capitalism on steroids society, where they're neglected and marginalized. The vulnerable will be deemed inconvenient and superfluous to our progression. They're just going to be on the side. And the cult of the young and the fit will flourish to the detriment of the old, the weak, and the poor. Lewis Laurie wrote The Giver. We are slowly advancing to the people of this novel, where what first appears to be a utopian society, where there's no hunger, there's no war, there's no suffering, ends up to be a dystopian society, because the people who lived in the society couldn't recognize music, they couldn't appreciate music, they couldn't recognize color, and they couldn't appreciate love. Which brings us to our most, like a very common Christian theological question is, without darkness, can we ever recognize the light? And in the absence of suffering, can the human heart truly appreciate all the good, the goodness, the truth, and the beauty of life? Again, going back to C.S. Lewis's quote, to love is to be vulnerable, but if you were to switch that around, to be vulnerable is also to love. And in our vulnerability, although painfully uncomfortable at first, we grow to trust, to open up, to endure, and to fully give ourselves to one another. In our vulnerability, we learn to become more human. Does anyone have any questions at all?
Thank you. Please come forward.
Thank you for that presentation. I'm Peter. I'm a family doctor from Pittsburgh. I have two-pronged question. One is, are you aware of, in the states or the countries that you mentioned where physician-assisted death is legal, are there consequences for providers that choose not to provide that to people? And the second prong of that question was, are you aware of any psychological consequences to those providers that do provide that for people?
So for the first one, in Canada there is not. So you don't have to be involved in the patient's death, even if they ask. For your second question, what was the repercussions if they don't do it? The psychological repercussions. I'm not sure. I haven't really encountered that, to be quite honest. Mm-hmm.
Please come forward.
Sorry for the long walk.
Mm-hmm.
I'm Katya Hill from Pittsburgh, and I participate in a Pittsburgh ALS clinic. And I, from my experience, would say, no, patient A would not be the person asking for physician-assisted, but patient B, that is now more afraid of being a burden on their family. Their spouse is working, their children are working, there is an expense, they want to leave a financial legacy. The first question I always get is, how much is this assistive technology going to cost? And I say insurance is going to cover it, but they're very much aware of the expense of having that diagnosis of ALS. So what do we do as a church community at the parish level, at a broader, national level or diocesan level of our church, so that those families that are the patient Bs are having a different perspective as to having a diagnosis that they know is terminal and understanding the gift that may be provided to them and to their families with that diagnosis.
Yeah, that's definitely a good point for patient B. I would say that the best thing we could do is probably emphasize the importance of suffering, and that there's actually a workshop earlier this morning. They said something like, sadness is not something that we should avoid. Sadness is part of the victory. And I think the same thing could be said about suffering. Suffering is part of the victory. It's part of the journey. It's not a hurdle like society wants us to think. It's not just, I bumped my knee, let's walk it off until it gets better. It's an ongoing thing. It's an ongoing journey for growth. And I think that's something that should be emphasized, aside from on a national orthodox policy making kind of thing. That's not for me to answer. So I would ask a bishop.
Any other comments to share? Well, thank you for a very
Thank you.
stimulating-